Zoll has pushed the boundaries of what is possible for 35 years, in the tradition of company co-founder Paul Zoll, a Lasker award-winning physician and a pioneer in pacing and defibrillation. In addition to his seminal research, Dr. Zoll had a reputation for dedication and careful attention to his patients. His legacy lives on at Zoll.
Is it okay? Can everyone hear me all the way back there? Okay, so just want to start off by thanking everyone for giving me the opportunity to stand in front of you guys here today and give a little look into a topic which is rarely seen around here, such as environmental medicine. So hopefully it'll be a little bit of a treat to see a practice that you had the opportunity to rarely see. Kind of already had an introduction, but my name is Kanak Naidu. I'm an emergency room physician. Used to practice internal medicine, but now primarily use emergency medicine. So there's multiple niches in emergency medicine. My favorite two niches are ultrasound and wilderness medicine. And I try to kind of incorporate those two as much as possible. So I don't think I'm going to be doing any more board certifications. Initially, I thought about doing a triple board in critical care, but I think I had enough punishment with these studies. Okay, so let's go ahead and move on with this little introduction. So before we move any further, let me just say what I believe this practice is not limited to the wilderness itself, okay? Even though it's called wilderness medicine, the actual name is Austrian medicine. So wilderness medicine or Austrian medicine can be anything really outside of your scope of practice or your scope of comfort, okay? So it doesn't have to be literally in the wilderness. It can be in the rural area. It can be in a situation that you're not comfortable with. It can be doing procedures with substandard materials or improvisational materials. So the availability, the variability in this above statement is how limited the resources that you're talking about, okay? So it can range from nothing at all to supplies that any survivalist or a wilderness medicine person carries with them. Really, with no equipment at all, it's nearly impossible to render assistance safely and effectively enough to stabilize a patient and transport him or her to a definitive care. So what I suggest, and for anyone that kind of goes out into the wilderness, that you kind of prepare a little medical kit and you kind of take it with you. Really, really basic stuff. So some of the things that I suggest are things like gloves. Sorry, which is the red? Sorry. So a pair of gloves, safety pins, duct tape. If any of you have ever gone into any stuff about wilderness medicine, this is going to be your life-saving equipment. Duct tape. It fixes everything. Okay. A little gauze and dressing. I'm serious. You can make clothes from duct tape. This is like the latest fashion. Like they make an entire dress out of duct tape. Adhesive bandages, a large plastic garbage bag, a couple of small Ziploc bags, oral rehydration tablets, IV tubing. An army knife is a great thing for any survivalist. Blister care, otherwise known as moleskin, and aluminum full splint, otherwise known as a SAM splint. So certain medications that I suggest that you always take with you. Pain medications, usually some ibuprofen or acetaminophen or paracetamol. Sorry. Some antidiarrheal medications such as loperamide, antihistamines, stethoscope if you have the space for it, and some oral glucose gel or honey. Preferably honey, and we'll talk about that later. For people, if you have in your group that have anaphylactic reactions, they really should be carrying an EpiPen with them. If not, if they tell you that this is one of the requirements, you can probably help them out and just carry an EpiPen with them for them. Okay, so whenever we talk about resuscitation in the wilderness, or actually in the hospital setting, everyone knows the ABCs. That I'm sure we don't have to go into that at all. And of course, if there's trauma involved, then there's A, B, C, D, E's. Okay, so but oh, yeah. So, but when we talk about resuscitation in the wilderness, it's important to kind of expand this a little bit, okay? So now when we talk about resuscitation in the wilderness, it's going to be the 3 A's, the 3 B's, and the 3 C's. When we get to the C part, I'll kind of change it just a little bit for one extra thing. Huh? So the wilderness medicine is the ABCs are now actually the 3 ABCs. All right? So when we talk about the 3 ABCs, let's talk about the A's first. 1 is assess the scene, 2 airway, and then 3 alert or assess others. B, barriers, breathing, and bleeding. And the C, cervical spine, CPR, and cover the patient. There's a last, not necessarily ever actually put in any of the literature, but call for evacuation. When we talk about the C's, when we get to it, along with a CPR, I'm gonna include circulation with this, okay? And we'll just talk a little bit about it when we get to that point. So let's start with the A's first. So in the urban setting, you don't usually have to assess the scene at all to make sure that it's safe, right? But in most instances, you're okay. But in the rural or wilderness environment, it does become the first thing that you need to do. I'll give you 2 reasons of the importance of this first. Rescuing a resuscitation person involving an avalanche, okay? So first, you need to make sure that it's safe to approach the victim before you start to deal with airway management and alerting others. So you'll have to make sure that you're safe or somewhat safe in this situation or environment. Otherwise, you start increasing the number of people that need to be rescued and resuscitated. In another instance, if this was an animal attack, you first have to make sure that the animal isn't in the vicinity before you go running into the situation to help someone. Yeah? Otherwise, you end up needing help also. I mean, I would want to approach, but just make sure that the encroaching animal is not in that territory. Yep. So, unfortunately, this is what ends up happening. People get a little too into the environment, have a really nice day, have a beautiful, what looks like a rainbow trout, and of course, there's someone else that's very interested in that rainbow trout also. Yep. So please make sure to assess the scene first, and then keep yourself safe so that you can go on to help others. All right. So with that said, let's move on to the second A, which is airway. Okay, so in a setting that you don't have all your equipment and you're outside of the hospital, how can you improvise an airway? So the first task is difficult enough as it is in a hospital situation, and it gets even more when you don't have all your nice little gadgets to deal with. So how many of you know how to still use a direct visualization? We've gotten to a point where we depend on machines and cameras and computers so much that we forget how to actually do the basics in which we were actually taught as medical students. Yeah? So everybody uses a CMAC. Everybody uses visualized intubation. I still think it's still very, very important that you know how to do it, just direct visualization. How many people still, do you still use just a plain Miller or a Mac to intubate? Yeah, see, so when you look at some of the younger people, none of them raise their hands. Yeah, and this is a bad situation. Okay, depending on electronics, battery-operated things has its limitations. Yeah, so you got to be really, really careful that you have a backup. All these things were actually set up as a secondary method. Somehow, it's just become a primary method now. So when someone is unconscious or semi-conscious, there's a generalized relaxation, including the tongue, and of course, that causes it to fall back, and this is what causes the obstruction, yeah? So normal, gets too relaxed, tongue falls back, blocks the airway. So some of the maneuvers that we use, like hyperextending the neck, jaw thrust, and chin lift, is all to move the tongue forward and relieve this obstruction. The tongue, when it falls backward, is what causes the obstruction, yeah? We don't really like using the hyperextension of the neck, especially when trauma is involved, because of the potential of the existing cervical spine injury. So we usually revert to just the jaw thrust and chin lift technique. With this, what we're doing is moving the tongue forward and relieving the obstruction. Now the trick in the wilderness is to maintain this position. Okay? So this can be done with the simple tools like, once again, duct tape and a safety pin. Okay? And this is actually done very, very easily and quickly. All you have to do is, with a safety pin, is move the tongue forward to the lips, and then easily and quickly, and most importantly, clip it to the lip, and it works. Okay? Okay. I didn't come up with it, so you don't have to clap for me, so I'm sure to clap before. So obviously, sounds very barbaric, but if you're using this, if you even have to come to the point of using this, the patient is probably unconscious. They're not going to feel it. Okay. All right. Otherwise, they can maintain their own air. Okay? So make sure to look inside the oral cavity after doing this to exclude any foreign body impaction. If one can be seen, it should be removed. Just like our basic BLS or ACLS, make sure you don't do a blind sweep if a foreign body is not seen. Make sure, another important thing, make sure that you pin the tongue to the lower lip and not the upper lip. I don't think they've done research on it, but I'm pretty sure it works a lot better. Like once again, I said, like, I know it sounds very barbaric, but they're usually unconscious and unresponsive, so they're not going to mind a couple of safety pins in their tongue, especially if it means saving their life and getting them to a definitive care. Okay, so remember, all of these things, these are measures in order to get a person safely and alive to one place or the other. So this is never a definitive thing, but it is a thing that can get you to a definitive area. So the last A is to alert others. Obviously, this is also very important because after doing all this, you have to make sure that this patient does get to where they need to be in a safe and effective time, yeah? And back to an urban setting. Okay, so now since we've finished the A's, we'll move on to the B's. Okay, so the 3 B's, all right, are barrier, breathing, and bleeding. So before we do the breathing, you want to make sure that there's a barrier between your mouth and the victim's mouth. I'm sure everyone has heard of compression-only CPR that can be performed, but be aware that this only applies to pure cardiac arrest. Okay, this doesn't apply to every CPR. Huh? It's only pure cardiac arrest CPRs that you can apply this CPR, compression-only CPR. And this applies only to bystanders. Okay, so this compression-only CPR does not apply to any of you. Okay, if you're a bystander, you choose not to start breathing into someone's mouth, it's absolutely okay to do compression-only CPR. Because there have been studies that have shown that just the negative pressure of recoil of the chest does cause some amount of air to actually come into the lung and enough to sustain the person temporarily. Okay, so barrier methods, yeah. So they do sell these little things that you can kind of take with you, little pocket masks. Of course, if you have all this stuff, that's great. But once again, we are out in the wilderness, and unless you are already prepared, which is the most ideal thing to do, then what you can do is, remember, one of the other things that we said was in our medical list was the glove. Okay, so all you do is you take a glove, you have your little army knife, you cut a little hole here, a little hole right here, and you shove these two into their mouth. Okay? This covers their nose and your mouth. So it provides a barrier between you and the patient. Okay? Another great thing about this is it allows a one-way breathing. Okay? And it does allow expiration, but if the patient were to vomit, it actually collapses this so that they don't vomit into your mouth. Okay? So when assessing breathing, you look, listen, and feel just like you normally do. You look for any injuries to the chest wall. You look for movement of the chest wall. You listen for breathing if a stethoscope is present, and feel for equal air movements. Of course, you can also check the chest wall for crepitations and check for the position of trachea. Looking for all these penetrating injuries into the chest wall can help you diagnose things like tension pneumothorax and things like hemothorax. So let's talk about tension pneumothorax first. So what can we do if you don't have a stethoscope present to help make a diagnosis of a pneumothorax or one that is significant? Okay, so percussion. Yep, I think we kind of stopped doing this now since now we have an x-ray. So percussion, okay? So it's an absolute shame if you're picking up a tension pneumothorax on chest x-ray. You're way behind. Okay? This is a clinical diagnosis. Okay? So you look, listen, feel, trachea. Yep. So, and you percuss. If it's large enough that you can hear it, it's a significant pneumothorax. All right? So, of course, with the pneumothorax, all you take is a wide bore needle, put it into the midline of the second intercostal space, and then relieve the pressure. So, of course, if you're in the wilderness area, you probably will not have an isolated just tension pneumothorax. You'll probably have a hemopneumo. Okay? So let's just quickly talk about the hemothorax. If you have a hemothorax, you leave it alone in the wilderness. Okay? A drainage of the hemothorax may actually increase the bleeding, and it is not recommended in the management, especially if it delays the management of this patient at all, to go to a definitive care. So what do we do when we're in the wilderness and the victim has a sucking chest wound? Once again, duct tape, savior of your life. Okay? So it's really, really simple. You take that little plastic bag you had, cut a little square, and you make a 3-sided tape and put it over the sucking wound. Yep. So it allows expiration, or it allows air to come out, but as soon as there's negative pressure and you breathe in, the plastic is sucked back in and prevents any further air from going inside. Yep. Really easy. Okay? So now let's talk about something a little bit more where everyone kind of cringes. Okay? A cric to protect the airway. Okay? I think very few of us probably have cric'd someone. Okay? But people with basic training can actually do this. Okay? All you have to do is find the location, which is easy. All you have to do is after that, take your index finger, find your Adam's apple, yep, and then, which is your thyroid cartilage, your largest bump in the front of your neck, and then slide it downwards until you feel a little tiny indentation. Yep. So you feel here, slide down, you feel your little indentation. Okay? That's your cricothyroid membrane. So obviously, if that's your cricothyroid membrane, that's your thyroid and your cricoid cartilage. Yeah? So that's the area that you're trying to aim for. Okay? So I agree it's a very tiny space, and every once in a while you'll second guess yourself by saying this can't be it and it has to be too small, and it is small. Okay? It's a small space, but it's very, very lax. Okay? And it's a very, very pliable space, so it kind of moves a lot. Yeah? So with now, all you have to do is just take your knife, make a vertical incision. Once again, if you're doing this, the patient's out. Don't worry about anything else, okay? You make a vertical incision right over it. There may be a little bit of bleeding, but nothing that we can't deal later on with a little bit of pressure, yeah? Okay, so you felt for your thyroid cartilage, you come down, you find your cricoid cartilage, right between there's indentation, and you make a vertical cut. Okay, you make your vertical cut, and then you need something to put inside this cricothyroid membrane. Okay, so once again, this comes back to my thing of saying you need to have some amount of material. Okay, so if you have all this kind of stuff like you do in the hospital setting, that's great, but you're not going to have all that. This is my favorite method, the Seldinger Technique. Okay, and that's how it looks when you go in. Okay, so if you don't have all this, it's absolutely fine. All you need is a 3 cc syringe, a gauge needle. You put this into this space, take the plunger off, and this fits into any about sized 3 or 4 ET tube, and you can bag it directly. Okay. Now, if you don't have that, if you have anyone knows what this is? This is from your IV tubing, yeah. Yeah. So here's your canister here. This. All you do is pull this out and jab it in their neck. Okay? Very, very sharp. You won't even need your knife. Okay? You push it straight in, and you can ventilate them straight through that. Okay? After this, make sure you secure it with duct tape. Another cool thing to do is make sure that it's designed for an ambu bag connector, yeah? So, we're a little rushed for time. So, going on to the third B. Here, you must expose the victim to a reasonable extent as not to expose them to hypothermia and check them for bleeding. If you're unable to expose them due to the environment or inability to remove the clothes safely, then you must feel inside any bulky clothing and check underneath the victim to make sure you see a site. I'm going to kind of go by this real quick because once again, we're a little rushed for time. So these are all your signs for shock, yeah? So just make sure you see all those for increased heart rate, respiration, pallor, cold peripheries, delayed capillary refill, altered level of consciousness. Okay? Apply direct pressure when you do see the wound. Okay? You don't have to tamponade the entire area. Just direct pressure is the best thing to stop bleeding. So of course, there's all these different kinds of tourniquets that you can buy. And now you have all these amazing things you can put right into the wound. I think this is one of the latest things that's coming up in the news recently. And you just put it right into the wound, push it right in, and it acts it just tamponades the entire area. Okay, but obviously you're probably not going to have that. So what you do is you create your own tourniquet. Yeah, you put a bandage around it. You put any kind of stick that you can find around it, tie it, twist it, and tie it again, and this creates a tourniquet. Yeah, and you just leave it just like that. So there's always this thing about being too worried about how long you can leave a tourniquet on. Okay, it can usually be left up to about 4 hours without having any kind of vascular damage. So, you know, there have been studies with the U.S. military that they've actually left tourniquets on for greater than 6 hours with great reperfusion of limb wounds that they've been able to come up with. Okay, so of course most of the fractures that we come up with are long bone injuries, such as this, and pelvic injuries. So, of course, there's a SAM splint. Everyone knows about those. I have no interest in SAM splints, so nothing to disclose here. If you don't have a SAM splint, you can make a long leg cast using just your trekking poles. Okay? And everyone knows about a pelvic binder with just a sheet of blanket. Okay? So coming up to the C's, there's cervical spinal protection. Okay? And then CPR. Okay, CPR is done exactly the way it is out in the hospital setting. Okay, of course, you assess every single patient, and every single patient should be considered to have a cervical spine injury. Okay, so we always protect them. You use the same SAM splint. Your duct tape, once again, is going to be a lifesaver, and you can make your. So what happens when your neck looks like this? Okay, so you gently, surprisingly enough, you actually gently move the neck back into neutral position, which I'm not sure of how many of us have, how big our stuff is to be able to do that, but that's what's recommended, okay? And then after doing that, you stabilize the neck, and you do a multiple person roll. Okay, just 30 seconds, I'm gonna just show some pictures. So this is actual stuff that we done while we were in Nepal. Okay, this gentleman has Meniere's disease, had a quick turnaround, hit the side of the bed, hit the left side of his chest, and was down. We did have a portable ultrasound, which did show a pulmonary contusion, no pneumothorax. We were able to package him up. That's me with a beard. And to move him out. Yeah? This is the world's highest helipad in Nepal. And in our training, we actually practice this on once a year so that we have that. Yeah? Sorry for going overtime. But I do appreciate everyone kind of being patient listening to me. Yep, I hope it was great.